This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME accredited course for advanced practitioners and physicians. Today, I'd like to review the most basic pulmonary function test, simple spirometry, also known as the forced vital capacity maneuver.
Let's stop and define some of the volumes and capacities of the lung. First, we all take regular, quiet inspirations in and out, and these are termed tidal volumes. Now we realize that we can take an extra large breath and fill our lungs up completely, and in addition, we have ability to exhale beyond the normal tidal volume to as much as we can empty. And those two volumes are termed the inspiratory reserve volume and the expiratory reserve volume. Now there's one more volume, the residual volume, that we are unable to empty out. It's the volume left in our lungs at the end of a maximum expiration. So what we see is we have four independent volumes that are mutually exclusive of each other. Now a capacity is the sum of at least two compartment volumes. So in this case, the total lung capacity is the sum of the four volumes we just went over, but there are some other capacities I'd like to make sure that we're all on the same page on. Vital capacity is the largest breath we can take. It's the maximum inhalation all the way down to maximum exhalation, or vice versa. There's one other very important lung volume, and that's functional residual capacity. It's the amount of lung left in our amount of air left in our lungs at the end of a quiet exhalation. That includes the expiratory reserve volume and the residual volume. So those two volumes together are the functional residual capacity. It actually serves as the resting point of the lung when we're in between breaths, not making any effort. That's the natural position of our lungs with respect to volume. Now let's talk about a spirometry maneuver, which is also known as a forced vital capacity maneuver. What we do is ask the patient to take a deep breath into the total lung capacity, hold the breath, and then on command exhale as hard as possible for at least 6 seconds towards residual volume. Important values are the total amount that comes out as the forced vital capacity. That's the vital capacity coming out under forced conditions. The amount that comes out in the first second is the FEV1. The ratio of the first second volume to the total exhaled volume is the FEV1/FVC percent, or ratio. It's also sometimes shortened to the FEV1 ratio. And finally, peak flow is the maximum flow rate achieved during exhalation. Spirograms are seen nicely on a graph. So what we have is we have the patient hold their breath at total lung capacity, and we set the cursor, or we set the graph at 0 arbitrarily. As the patient blows out over time, measured in seconds, the volume comes out towards a final volume, and at that volume, the patient's at residual volume. So the forced vital capacity maneuver is a maneuver where the patient starts at total lung capacity, blows out as hard as they can, the air comes out, and they wind up at residual volume. So graphically, we see at the 1 second point, we can see how much volume came out. That's the FEV1. We can see the slope of the graph is the flow, how fast the volume is coming out per time. So the steepest slope, indicated here by the green line, is called the peak expiratory flow rate. Only at the steepest point can we measure the peak expiratory flow rate. In a healthy person, we see that the flow ends by about 2 to 3 seconds, and after that, there's no more emptying. The curve is very flat. In a non-obstructed patient, we see a plateau well before the 6 seconds. 6 seconds are up. We do like our patients to blow out at least 6 seconds to make sure they have ample opportunity to empty all of the air that they can possibly empty out of their lungs. So in this example, the FEV1 is 4 liters. The vital capacity here is 5 liters, and the ratio of FEV1 to FVC is 80%, or 0.8. The peak flow is about 8 liters a second, meaning if they had 1 second to go, this would have risen by about 8 liters for each second. That's the slope of the graph. 8 liters, which would be up here, for each second. Now, it's really only at the peak flow for a tiny bit of time. It's the inflection point where the graph is the steepest. First, the slope is going up, and then the slope is getting more gentle going down. So the peak flow is read at the inflection point where the slope is the steepest. So the next thing we can do is we can plot the flow at each volume. So we do that by having a two-phase curve. Above the x-axis is outward flow during exhalation, positive flow leaving the patient. And then later on, the flow is inward. It's negative flow in the opposite direction. That's inhalation flow. So what happens here, if you go step by step, is the patient holds their breath at total lung capacity, right over here, and then they blow out real hard, and the flow goes up at each volume until they're all the way at residual volume, and in that case, the flow is 0. Now we know, since this is volume, the distance from total lung capacity to residual volume is the forced vital capacity. So at each point of the volume going from total lung capacity to forced vital capacity, we know what the flow is, and we also know that the peak flow in this case is around 8. Now on inspiration, the opposite happens. There's inward flow. The patient fills the lungs up rapidly from residual volume, big negative flow as they pull in real fast, and then it slows down until they're finished. And at the end, if they did the maneuver right, they'll be close to where they started. They'll have their lungs filled at total lung capacity. So this explains the general shape of the flow volume loop, and I show a very normal looking flow volume loop. So in a good effort, the peak flow comes early on before much volume comes out, and it's fairly sharp. It could even be sharper than what I'm showing you right here. This is a little bit rounded. The better the effort, the sharper the peak flow is. In this example, the peak flow is 8 liters per second, and that corresponds to a peak flow of 480 liters per minute on a peak flow meter, since there are 60 seconds in a minute. Now I'll show you some patterns of abnormality. The first pattern is mild obstruction. What happens with the spirogram is the patient holds the breath at total lung capacity, but rather than having very steep, high level of flow, that 8 liters per second or 480 liters a minute, you can see the tangent of this, or the steepness of this curve, is less steep, meaning there's a lower peak flow. And we also see that the patient really has trouble plateauing. They're still emptying out between 3 and 6 seconds. So just this curve alone is very suggestive of obstruction. So here's the peak flow being low. And this is the concomitant or the concurrent flow volume loop. I put the normal loop in white dots for reference. We'll see that the peak flow is lower, and that can be measured by the patient at home with the peak flow meter. Although the peak flow, I have to say right now, is a little bit unreliable because it's very effort dependent. So we have to take it with a grain of salt. We always make sure patients do this maneuver in triplicate because it can change between maneuvers. We actually see the mid-flow at the mid-volumes, the middle volumes, we see the flow is particularly suppressed, causing a mild pattern of what we call incoving. And we may see a very slight drop of vital capacity with mild obstruction, but in mild obstruction, the vital capacity may not be affected at all, because they can eventually empty all of the gas. Contrast this with severe obstruction. We see the flow is very suppressed, so the peak flow is very low. The FEV1 is extremely low. At 1 second, they're a very small percentage of where they should be, and there's very poor flow. They're still emptying at the end, and they haven't even come close to emptying what they need to empty to get back to their vital capacity. Now remember, just because they have a low vital capacity compared to normal does not mean that they are restricted. That's pitfall number 1. So here's the flow volume loop. The peak flow is very low. We saw that with the slope of the green line up here being a gentle slope. There's severe incoving. The vital capacity is low, but we don't want to call this small curve restricted. That would be a pitfall. Now in restriction, what happens is the flow is actually preserved. There's pretty good flow over here, but the vital capacity falls short. So we have a fairly normal looking curve, it's just too small.
Today, we reviewed the clinical utility of simple spirometry, which is also known as the forced vital capacity maneuver. There are two other components of pulmonary function tests that were not covered today. The first of these is lung volume determinations, which measures the total lung capacity, including residual volume, using either nitrogen washout, helium dilution, or body box plethysmography techniques. The last component of complete pulmonary function tests is the lung diffusion capacity determination, which it's used to ascertain intrinsic membrane function by measuring uptake of carbon monoxide tracer across the lung membranes. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.